All right, let's talk about Kawasaki's disease. So the differential for Kawasaki's disease are viruses that cause exanthems, specifically adenovirus. Group A strep pharyngitis can also cause a rash, that sandpapery rash. Measles, Stevens-Johnson syndrome, and Epstein-Barr virus or mono. Predisposing conditions, there's really not a lot known about that part of Kawasaki's disease. It's thought that possibly viruses may induce this type of vasculitis. Pathophysiologic insults, so it's inflammation of the medium-sized arteries, otherwise known as vasculitis. Clinical manifestations, so to be considered for Kawasaki's disease, you have to have at least 5 days of fever. And then on top of that, there's 5 criteria that can occur, but not in a specific order or at the same time. So first, this bilateral non-exudative conjunctivitis occurs in greater than 75% of patients. You can have erythema of the lips and oral mucosa in 90% of patients. And this can also have cracked lips and strawberry tongue. Then you'll see extremity changes as well, which is usually swelling and can be peeling of the skin in 50 to 85% of patients. And then this unilateral cervical lymphadenopathy in 25 to 70% of patients. And then a rash, which is in the 70 to 90% range. It usually starts on the perineal area with erythema and desquamation, and then progresses to a more morbilliform or targetoid lesion throughout the body. So the biggest clinical manifestation and the biggest risk of not treating Kawasaki's disease are the development of coronary aneurysms. And so this can occur in patients who go 10 days with fever and no treatment of the Kawasaki's disease. And so it's the big reason why we try to treat these kids between day 5 and day 10 of fever. So when we think about evaluation, we diagnose off of that criteria. You have to have 4 of the 5, and then you also have the 5 days of fever. Once you're diagnosed with Kawasaki's disease, you get an echocardiogram done at baseline just to evaluate if there's any coronary aneurysms, and then you get a second one repeated several weeks down the road after treatment. Labs aren't always necessarily needed to diagnose Kawasaki's if it's a clear-cut case, but you can get LFTs, CRP and SED rate, all of which may be elevated. It is interesting to note that a SED rate can be falsely elevated due to IVIG. A CBC may show a decrease in lymphocytes, and then we typically do see a markedly elevated platelet count. Remember, platelets can be a measure of inflammation. And then in a UA, you may see a steropiuria, so white blood cells in the urine. And this is due to inflammation of the urethra. So if you cath a patient for a urine specimen, you will miss the white blood cells because the catheter will go up into the bladder. So if the patient meets the 4 out of the 5 clinical findings, and this is your typical case of Kawasaki's, sometimes though there can be atypical presentations as well. So treatment, the goal is to prevent coronary aneurysms. And so we use IVIG and then we use aspirin. And those 2 together help with both inflammation and then the coronary aneurysm complication. So IVIG is thought to modulate cytokines and decrease the antibody production, as well as augmenting T-cell suppressor activity and providing anti-idiotypic antibodies. So what anti-idiotypic antibodies are, that's basically saying that the body has this autoimmune response which is causing this vasculitis, and we're throwing in immunoglobulin, and then that confuses the autoantibodies, and the antibodies tie up to the IVIG as opposed to attacking the vascular wall, causing the aneurysms. Aspirin itself helps with both anti-inflammatory properties and anti-thrombotic properties, but it is not the main treatment for Kawasaki's disease, and that is IVIG. So that's a big test question. IVIG is the key to preventing coronary aneurysms and is the main treatment for Kawasaki's. So after we treat we observe for 24 hours to make sure that they are fever-free. If they do develop fever, then treatment becomes a little more complicated, where we may increase or we may continue this IVIG and introduce other things such as steroids and that type of thing. So this concludes our talk on Kawasaki disease.